ласка, ви могли?
Я допоможу Тетяні з демонстрацією, тому давайте
тоді-
я перевірю,
Д-
чи
Дякую.
вийде працює.
Я теж Тетяна, і в мене слайдів не буде, але чи мене чути?
Чутно.
З точки зору трансляції ми повністю готові. Скажіть, коли будемо починати?
Добре, скажемо. Я думаю, що буквально кілька секунд. Маємо 26 людей вже на дзвінку. Я зараз дивлюся на перелік учасників та учасниць і шукаю ще одну промовицю Младену. О! Ось вона приєднується. Тоді ніби з нашого боку всі в зборі. Так, я думаю,
medical education development. We started our work in December 2018, and we had the goal of improving the quality of medical education and the quality of primary health care through this education.
А освіта – це є як ніщо інше.
And education is nothing but a very critical thing for development of human resources and human HR capacity. Unfortunately, we are now seeing the aggressor country doing some inadequate manipulation with education, which lead to globally catastrophic consequences. We really believe that in our country, we pay enough and much better attention to education, and in our project, we really value the people and their development. And people from education and nurses, doctors, health managers who develop themselves professionally, they improve the quality of care as well as the quality of the system of education. As the project, we provide systemic support to the facilities, institutions to find the points for possible improvement and strengthen the competencies and processes, which eventually is very well felt by the patients and students. And in the recent years, our project in particular has been implementing the pilot of strengthening the role of primary care nurses. We do it together with 8 pilot facilities, primary health care centers. Now, talking about the pilot and the experience and the first outcomes, I think we can speak about it a bit later, and in a few months we'll call you to another meeting. But today I would like to present the results of the study that was sort of baseline for our pilot. We conducted it more than a year ago, and because of the real rage of the recent months, we are presenting the results only now, but I believe those results are still relevant. As in our research, we studied not just the practices, but also the needs in education and expectations of health managers, doctors, and nurses. During implementation of this pilot, we check it against the results of the study, and we would like to present those results now. You'll have also access to the report in hard copy if you need it, or in soft copy. It's available on the website. But in addition to the report, I'd like to draw attention to the fact that we've published policy brief in which we cover the European practices for nurses who have more responsibilities and roles in primary care. We check that in the context of education and teamwork. That is why currently we would like to share those results with you. We would like to eventually hear from you, your impressions, your comments, remarks, maybe some proposals or suggestions, because quite probably we will try to repeat this study a bit later to see whether something has changed. So my colleagues will be happy to share the news about that study and the results, the findings that really inspire us to implement further activities. Thank you. Thank you. Then I will share the screen. I don't know whether you see this. Now we don't. Okay, then. I think I'll have to check it. How it works.
Так. Так видно. Так.
Okay, so this works this way. Now you can use this QR code to scan. You can scan it if you are uncomfortable visiting the site, and download a soft copy of the report. But if you want to have a hard copy of the report, you can fill in the form using this QR code, and you'll get this printed version of the report. Now, let me stop here, because maybe you need to actually use this QR code to scan it to get the printed report. And let me return to this, to the downloading. So while you are doing that, I will tell you that today this study will be presented by the following panelists. It's Darina Bogdan. She is the coordinator for development, capacity building, monitoring and evaluation of our Swiss-Ukrainian project. I see Darina with us, also with us.
Яка є директоркою
Ms.
департаменту
Mladena Kačarec, director of the Education and Development of Personnel Department of Dobrobut Healthcare Network. Mladena. Also, we have here Matvey Khrenov, who is the co-founder of the Ukrainian Healthcare Center, and he coordinated the pilot project Advanced Responsibilities Nurse of the Medical Education Development Project. And also we have here Tatiana Guruk, a nurse of the primary health care center Yubileyny in the city of Rivne. Good evening, Tatiana. Yes, good evening. Well, I think everyone now has been able to scan the QR code to download the findings of the study and the report. And my first question will be to Darina, who, together with the team, collected and then reviewed the data about how the roles and responsibilities in primary care look like. So, Darina, please tell us about the results of the study, how, according to your data, those roles are divided. And second is, what was a surprise for you personally in the findings of the study? Yeah, I will try to start the presentation first because I did prepare it. I'd like to show some visuals to you in addition to what I'm going to speak. Okay, so you see this, right? Well, first of all, I will probably repeat what Tatiana has said. The study was conducted more than a year ago. But I thought it's, well, unfortunately or luckily, it's still relevant because it's a question about distribution of the roles and responsibilities of the doctors and nurses, and this advanced role of the nurse. And so this is still relevant study. And being a part of this pilot project for advancing the roles of the nurses, I may tell you that we can observe it quite closely how it happens. So today we did not intend to speak a lot about the purpose and the methods of the study, but to give you some impression about the scale of it, I'd like to know just two things. First of all, we contacted more than 250 primary healthcare facilities, well, private, public, from all around Ukraine. And we conducted more than 600 we had more than 600 respondents to questionnaires among health managers and doctors, and more than 20 interviews with experts. Well, it's just to give you the idea about the representative nature of our study. Well, okay, I would like to use this opportunity because it is the first presentation, so I will probably speak something that Mladena would also like to mention later. That's a quote. We wanted to check the distribution of roles and responsibilities, and what we saw that it doesn't exist, neither formally nor in practice, and most of the respondents agree with that. And what does that mean? That means that we need to go and distribute those roles and responsibilities in practice within the teams, within the facilities, between the doctor and his nurse or her nurse, together with health managers or without them. If we speak about de facto situation, I think this picture on the slide is familiar to many. But the study allows us to sort of digitalize and provide data behind this picture. So in 90% of cases, a doctor and the nurse are present together when the office is visited by a patient. So the difference only in how they place those tables, but in 90% of the cases we see one computer, someone working with the PC, someone is consulting the patient, and that's how it happens in most cases. The rest are either, well, when the doctor sees the patient without a nurse, or there are those yellow cases you see. which indicate the situations of separate work with the patients, separate work of nurses and doctors. So based on the data we received, we tried to sort of generalize the picture, and the main finding was that we identified 3 models for role distribution. So I will speak about them in a moment, but first another quote, because I cannot just drop the qualitative part of the study. I like it so much. So there will be a lot of quotes in the presentation. So this 90% joint work is based on historic perspective and experience of doctors and nurses. They've been working together for tens of years, and it is why the role distribution looks like that. And they work using 1 or 2 tables together. But if we return to the distribution of roles, we identified 3 typical models. So the first is the traditional model, when the doctor treats the patient, does all the clinical functions, and the nurse also only does administrative work and paperwork. And unfortunately, on these pictures, you can see that, and it is reflected in the practice. And well, based on the data we received, it is 90% of the cases. Second is something we call the solo practice of the doctors, something that is practiced more in private facilities, where the doctor doesn't have a nurse in their practice during the care encounters. And the third one is substitution of the doctor, where usually when doctors are not available, mostly in remote localities or where they have only a feldsher. Yeah, so because there is no doctor, the nurse has to take on all those clinical functions to sort of replace the doctor. It was interesting to see that this situation, well, most of respondents are okay about this situation. They're satisfied with that, because when we asked them about the satisfaction of the current distribution of responsibilities, more than half of them were either rather satisfied or completely satisfied in more than 50% of cases. On the one hand, we could say here, okay, then there is no need to change anything. But on the other hand, we see that from a quarter to maybe 20% of them are not really satisfied, and they are willing to try some other practices. And eventually, the other models showed that, people actually try using other models of care. Now, we went further and tried to learn whether there are doctors, nurses, and health managers willing to provide more responsibilities to the nurses, to give the nurses more tasks. So as you see on the slide, in fact, they are ready to that, and they are willing to expand the responsibilities of nurses. And here is a bit of the response to the second question by Victor, what I was surprised about. I was really impressed with the fact that the nurses believe that some of the tasks of the doctors can be delegated to actually nurses. We heard about that a lot in the study, and on the one hand, it was about education, like Tatiana said, about building the capacity of human resources, about the teamwork, the trust. Well, this is something that prevents increasing the percentage of nurses who believe that they can take on the responsibilities of doctors. What we see then, more than half of health managers are ready to that, and almost half of the doctors are willing to delegate some of their responsibilities to nurses, which is important, and as it opens the opportunity to actually move in this direction. So if we speak about the model of solo practice, as I've already said, it was practiced by the private facilities. It was practiced because it is more cost effective. And you see it on this quote. They say that if a doctor encounters the patient alone, they won't have to pay to the nurse who only makes injections or drinks tea. But then there is a question why the workload of nurses is so low. And the private facility people say that in long-term perspective, it will not be about cost effectiveness, because cost effectiveness with a larger number of patients will be about combination of the teamwork of doctor and nurse. And the final model I've mentioned, the substitution of a doctor. Its key challenge is that it functions until the moment the doctor comes to the office. The nurse can do everything unless the doctor is present, because whenever the doctor is here, she goes back to her administrative role or secretary role, and not to counseling the patients or providing care. It shows that there is an untapped potential, because the nurses actually practice more functions, but in very rare situations when they are given this opportunity, actually. Now, talking about the knowledge and skills, it's also important, and it's a sort of discovery of our research. It's the question about, well, whether the nurses have sufficient knowledge to practice at primary care level or get more responsibilities. What we saw here on this slide is mostly respondents said that the skills are sufficient. So from 54 to 75% of them agreed. But if we check the blue part of this chart, we see that from 19 to 31% of the respondents, they believe that a nurse can do more with the competencies she has. It's just that no one gives her these tasks or responsibilities. So I tried to sort of present it, or I'm not sure whether it is obvious what these circles represent. If we present the previous slide for different types of practices, in blue it's the scope of practice, and in red is the scope of competency. So in 20 to 30%, we see that the competencies significantly expand the scope of the practice that is given to them. So the potential is clearly not used to its full capacity. And again, there are people who believe that nurses lack competency. It's, you see, from 2 to 15% of the respondents. Well, they believe that nurses are not competent enough. But most of the people say that the scope of the competency is adequate for this scope of responsibility. So it should be like, okay, they do what they know how to do. But on the right, I tried to focus on that. The question is to expand both together, both the competencies and the scope of practice. And it is quite risky to do something separately. By expanding the competencies and not giving the opportunity to perform those functions, will simply demotivate the nurses. We will be underusing the human resources, and in fact, the primary health care will have problems with the quality, and the patients will not receive the necessary scope and quality of the services. Well, I see that my time has run off, so I'm probably stopping at this. And I would like just to say that on the left, talking about these circles, there are different strategies about how to move to the right side of the slide by expanding the scope of responsibilities and the scope of competencies. And that's why we implemented the pilot project. Thank you very much, Darvina. I see that in the chat we see some comments and questions concerning this factor of wages. I think we'll return to this a bit later, and right now we are like parking this question for the Q&A session. So now I would like to let me now share the screen, and I would like to give the floor to Mladena, who reviewed the legal framework for the work of primary care nurses. The spoiler, she says that there is no fixed distribution of responsibilities and everyone does it in their own way. So the question to you, Mladena, what can nurses do at primary care level and what they cannot do, and whether their responsibilities can be legally expanded in a facility? Mladena, please.
Так, доброго дня.
Yes, good afternoon. I would like to congratulate everyone with the end of air raid alarm that we had. And I would like to apologize for the quality of the connection, because I had to find some place where they have both power supply and internet. So I would like to provide the presentation. I need to share my screen for that. Do you see me? Do you see the screen? Do you see the presentation? Yes, we do. Yes, in fact, when we considered the legislation, we expected to see this result where the nurses have significant limitations in terms of their professional responsibilities, but we were surprised by the results. Why? I would like to draw attention to the fact that we analyzed the legislation as of 2020. Of course, in 2 years, there have been changes. That is why please take that into account. Something could have changed, not much, but the general trend is, before the study, the picture of a legal regulation of nurse work looked like something on the left. You see this black and white picture. And after the study, when we try to somewhat classify those, maybe categorize those legal acts to identify more or less relevant of those, it looks similar, but it is more of different colors. It's brighter, but still it is very, very confused. Now, if we look at this general picture, we can say that all the documents can be categorized, divided into international acts, special laws, and bylaws, which sort of detailize the scope of responsibilities. And I would like to draw your attention to one of the key international documents. It's the Munich Declaration of the WHO, adopted in 2000, where for the first time we see a lot of attention paid to the family nurse and the role of the nurse in family medicine in the primary care level. And it is in this Munich Declaration that they clearly announced the importance of strengthening the role of nurses in public health and community development, basically in the part which is the focus of activities of primary care. And again, if we categorize those acts based on the content, there are declaration documents identifying general rules and responsibilities, and they speak broader about the role of nurses. That's a document on actual activities, and the documents that are, well, indirectly concerning the activities. Well, if you speak about the direct documents, those are guidelines for nurses, or the order on provision of primary care, and a number of other documents identifying the role of the nurse in primary care. And those bylaws, which indirectly concern the activities of the nurses. Mladena, I'm sorry, I believe we have lost you. Yeah, I have the feeling that I have a technical problem with the internet. So we now to wait a few moments, maybe she will return, because otherwise I see Matvey here who is ready to present his part. I think that if Mladena gets her internet back, she'll return to us, to our presentation. And meanwhile, I will have to ask Matvey. So that the preliminary, summary, it's what Darina spoke about and what Mladena also mentioned. Yeah, I'm back. I'm back. I'm sorry. Yeah, we have problems with the connections here, but I'm restarting the presentation now. Okay, so this is the whole scope of the legislation that concerns the responsibilities of the nurses, or maybe it does not identify all the responsibilities, but it basically speaks about different aspects of it, like hygiene of hands, for example, or some other general things, general for health workers, including nurses. So I would like to draw your attention to the Article 35(1) of the law on healthcare. It provides general description of the role of the nurse. It says that the primary care is provided by family doctors, other specialist doctors identified by the regulator, and other health workers subordinated to the above. That's one of the most important, most basic foundations for further identification of the role of nurses in primary care. Another important point is the reference book on qualification characteristics, edition 78. It's a unified document identifying qualification of every health worker in the system. But again, it has a lot of small points because, there have been many changes, new professions added. But on the other hand, the old ones remained So we have quite an imbalance here. For example, there are 3 different managerial positions for nurses, and their functional responsibilities are pretty much overlapping. So it's not clear whether a primary care facility has to have all 3 managerial nurses. That's the chief nurses, coordinator nurse, and the senior nurse, or the facility can choose to have only one of them. So there are differences between them, of course, but they are not completely significant, those differences, and prevented them from combining the functions. And if we look at other types of nurses, we can see that on primary care, there is a whole variety of different nurse positions. That's a general nurse, it's a nurse of a children's polyclinic, the family medicine nurse, massage nurse, functional diagnostics nurse, and so on. So all these positions can be found in primary care, depending on the scope of care provided by the facility. Order number 504 of the Ministry of Health, dated 19 March of 2008, is the very much used document for primary care level. It was innovative back then, and it's another pillar providing this responsibility for strengthening the role of the nurse. It mentions the idea of team providing primary care. That says that it includes several people. One of them is a doctor, and other people are any health workers working under the leadership of this doctor. So it doesn't speak about a nurse only. It can be another doctor, it can be a feldsher, it can be a obstetrician, for example. So it says that there must be a doctor and other people supporting the doctor and subordinated to the doctor. So basically they work together and led by the doctor. So the primary care doctor, as the head of this team, is the person who sets the responsibilities of the nurse. Also in this report, you will be able to see how the reference book of qualification characteristics identifies the competencies of and functions of the doctor and the nurse. So basically, if we analyze that, we will be able to see that the doctor generally identifies the scope and the practice of treatment and the practice of use of medications, and the nurse is the person who implements the decisions of the doctor, so she can do it independently based on the decisions that have already made by a doctor. For example, providing a prescription to insulin to a patient with diabetes, or conduct some primary examination of the patient, or vaccination as a function that doesn't require significant involvement of the primary care doctor. So on this slide, I would like to demonstrate 2 things. The first is when we speak about the competencies of a nurse and about shaping those professional skills. So if you look at the reference book, we see that the nurse needs to know and be able to do everything. So if we review, for example, the provisions of that saying, for example, that the nurse needs to follow all the norms and legislation in healthcare, which is impossible, obviously. She cannot know all of it. And these are things that on the one hand they are meaningless, but on the other hand they set very high bar for the nurses. And then meanwhile there are ways to sort of be flexible about them. So on the one hand, this ambiguity of the formulations of these phrases, it encourages people maybe to avoid the initiative for expanding the responsibilities, because if something is not written there, I cannot do this. That's their position. But on the other hand, if we follow the Order 504, we can see that in general, the provider of primary care services, it's either a facility or an individual doctor, they can provide such job descriptions for the nurse that can enable them to work effectively, to provide care, well, as effective as they want. So basically, this flexibility opportunity is provided by the legislation of Ukraine, and that's a good thing. Now, talking about the recommendations in the report and something that we would like to draw attention to, well, first of all, systematization of this legislation and those regulations covering the nurse activities is very relevant now, because the orders keep changing very often. There are very obsolete things people still follow. If you speak about nurses, well, simply because there was a miscommunication some time ago and they keep using obsolete documents, but they don't pay the necessary attention to the new guidelines. So there should be a platform or online resource to enable working with up-to-date legislation covering the nurse activities. Second recommendations is to use the opportunities provided by the legal environment, legislation framework, and expand the roles and responsibilities of primary care nurses, because their educational and qualification level is sufficient. It gives them the opportunity, for example, to do vaccination. And the third important vaccination is to remove the collisions and discrepancies in this reference book of the professional characteristics through creating a new professional standard for nurses. There is a methodology of the Ministry of Social Policies and the Cabinet of Ministers creating new professional standards. In healthcare, we still have no professional standard, even though several years have passed since the process began. So then nursing could become the sort of pioneer in creating such a standard, covering all the competencies and responsibilities, giving the nurses the opportunity to be flexible about changing their professional or career trajectory, to change their activities, switching from primary care to secondary care, and so on, without extra red tape, without too much manipulations with the CPD, and clearly identifying the ways to do certain things. So at this, I would like to stop my presentation. Thank you very much, Mladen. I think that there is some space for clarification, which we will leave for the Q&A session. Now, the colleagues, those who have joined a bit later, I will send again in the chat the link to the report of the study, and you will be able to see in full all the charts concerning the questions asked to health managers, doctors, and nurses. And one of the slides shown by Mladena, that's a superhero team, actually makes me ask this question to Matvey, because the teamwork in primary care is the key. And the question here is whether the actors of primary care are ready to expand responsibilities of nurses. So we remember from that slide that all the participants are more willing to do that than the nurses themselves. So this question about preparedness probably can support the process of expanding the responsibilities of primary care nurses. Thank you very much. And I have a slide on this actually. Tarina, please show the second slide. So I will go to this immediately to answering this question. And while Mladena someone said that there is a free cashier, I understood that I really wanted to, I was really hungry, but whatever. Let us speak about the business here. There is a more complicated slide, and it's about who and how much is willing to expand the responsibilities of nurses. And so this is the situation when the health managers are more interested in delegating responsibilities to nurses because they understand that they can expect some result for them. Doctors are less willing, and nurses are totally unwilling to do that. But as Tatiana Chernish has said, we are conducting the pilot. And the first stage has already been performed, and we'll share the results with you. The name of the pilot project was the Advanced Nurse. We tried to find the opportunities to, under the current legislation, to provide more responsibilities, build a bigger role for the nurses. And our hypothesis was that the main beneficiaries of this project would be health managers, because they would understand that they needed a more effective nurse for their facilities to be more effective. And we really stressed that, it's not about like making nurses work more and then you will need less of them. No. The nurses in primary care have so many functions, so that to perform them in a good quality, the doctors need the support of a very qualified nurse, and this cannot be just a nurse who just sits in one room with them and only types something in on the PC to produce medical documents. So one of the conclusions we've come to implement in this pilot is something that we see. It is not yet supported by the data, but that's the feel of it. Just answering the question, I would like to say that really in efficient primary care centers, the biggest stakeholder, the most interested party is the health manager. But when a nurse wants to develop, when she is motivated, and we believe that if she does more work, she needs to get some preferences, some incentives, material and non-material. When she understands very well what's going on, they have good communication with the doctor, the motivation to change is bigger. And at the facilities where it has already started, I think that the support of this idea will only increase. And I want to say once again that we don't have the task to force or to motivate all the nurses to do more right away. It's important to do it step by step for those who actually want to do that. And those changes must be supported by incentives and by giving the person more authority, more respect in the collective, and be more responsible. And those people are willing to take responsibilities because they didn't go to universities to simply type in some recommendations, especially the middle-aged women, the core of the nursing system. They actually want to do more. So the next slide. So this is the key slide where you see who, as of a year ago, was supporting this change and was willing to undertake more responsibilities. The next slide, I would like to show, well, to illustrate it with a case, talking about what actually doctors are willing to delegate and nurses are willing to uptake. And you see that the percentage of the procedures, especially if we speak about the collection of blood samples or monitoring of the condition of the patient, is quite high. The doctors are willing to delegate that, nurses are willing to undertake that. Well, collecting the complaints of the patients is quite high level, but here the experts and managers, they have different opinions. But returning to our pilot, if you train them properly, if you explain to them how the information needs to be communicated between the nurse and the doctor through medical documentation, there is a bigger trust to this process. And the next thing is subjective examination with auscultation. Of course, most of the people are not willing to, well, give this function to a nurse. But again, when we did the training and the trust to this increased, because if you simply give the examination to a nurse without auscultation, the level of confidence would have been much higher. The next slide is another case, a patient with a 53 years old with diabetes mellitus second type. Said he had tingling in the toes and a wound on the foot, which is a problem. So there are many things that a nurse could do in such a situation. For example, taking blood sample for glycolized hemoglobin or measuring the sugar in the blood with a glucometer and explaining what this diabetic food is. So that's a part of work that nurse can, under the legislation, and should actually do. Next slide. After the review of legislation, here you can see the list of the things that could be transferred, the functions that could be transferred to nurses. That's providing health certificates, vaccination, prevention, examinations of healthy people, the responsible parent in school, management of chronic diseases, providing prescriptions for medications and other important things. And on this next slide, the question we analyzed was, what do they expect from such a redistribution of responsibilities? As of a year ago, people not involved in the pilot, what was their general expectation? And it's interesting that I'd like to draw attention to that managers spoke about the increase of the wages of the nurses, and someone mentioned trust here. Yes, you see, slightly more than a half of nurses believe that if they get more responsibilities, they will get more wages. And basically, from the point of view of nurses, few of these points got a good percentage, unlike the managers, because usually health managers are more optimistic about these processes. And I think that's an important point that needs additional study. And the question of confidence is among the top 3 reasons why this process is not going on yet. So the important point about the reduced workload of doctors, 90% of managers believe in that, but only 64% of nurses believe so. And the lowest thing here is the improvement of the quality of services provided by to the clients. You see, again, health managers are more optimistic about it. So we need to work with the trust. And this trust must not be bound to words set. It must be reflected by actually implementing these things. And if they are implemented in a good way, in an effective way, then the trust of the nurses to this process will be growing. So that's my like biggest conclusion, and I would like to give the floor to the next speaker. Thank you very much, Matvey. And I would like to ask Tatiana, now as the practicing nurse, what are your impressions from reading this report, or maybe from the presentations of their colleagues? Do you agree or disagree with it, and how it actually works out? Because you operate with such a generalized data, and please share your opinion about what you've read and what you've heard here. And the second question will be about how, in your opinion, these barriers need to be removed on the level of nurses to let them be able to do this and let them be willing to expand their role. And well, what doctors and health managers need to do to create the situation where such change is possible. Yes, thank you very much. Today I represent the team of the nurses working at the Jubileely Primary Health Care Center in Rivne, and I'm a bit surprised about the results of the study because I believe that our nurses are progressive, but I think, well, I recall ourselves at the beginning of the projects, we did have doubts. We were not sure that we would be able to make it, because according to our job descriptions, we always work under control and leadership of the doctor. We've never provided care independently. We were not sure about whether our education was sufficient to work independently from doctors. Maybe the results show that the nurses just have not tried that. And we'd like to present the steps of our success, because I believe we have achieved some success. We were not afraid, and with the support of our administration and the project, we tried it, and we are satisfied with the outcomes. Darina, could you please show the next slide? Okay, we were inspired initially by the intensive training session at Zhytomyr Health Institute, because there we learned more. We improved our skills for auscultation, resuscitation, ECG, vaccine prophylaxis, supporting the healthy people, motivational counseling. We were taught how to do that, and it really inspired us. But the biggest inspiration came from the speakers, because those are people we only saw on YouTube before. But here we understood that we nurses are important, because Irina Volosina, Fedorova, other speakers, they were really inspirational speakers. And after that Zhytomyr training, we came back home like having our batteries recharged, and we wanted to share our knowledge with everyone. We conducted a number of trainings at our laboratories. We shared the knowledge with the colleagues. We saw that we were able to inspire them as well, that they would also like to try that. And after the Zhytomyr training, we started seeing the patients ourselves independently at the pre-doctor offices that we have, because I like things like we see at the study tour in Croatia, where they have the neighboring offices of the doctor and the nurse. We don't have that because of the way our polyclinic is built. So it was decided that we will conduct such examination in pre-doctor examination offices, where they have everything required to collect the patient's history and anthropometric data. There are ways to measure the eyesight and the height and the weight. We have glucometers and centimeter lines. We have the calculators to calculate body mass index. So everything required to examine a patient. So yeah, initially it was one patient a day, maybe several patients a week, but we really enjoyed the fact that we were out of our comfort zone. We went to those offices, we examined the patients, and I always asked them whether they were satisfied. They were satisfied. Yeah, they trusted us. But when the COVID hit, the doctors delegated
Передали медсестрам, тому що
some of the online counseling to the patients, to us, and nurses had to carry that out because too many patients approached us, and doctors could not do that. So we monitored the stable patients with COVID, and checklists were a big help, allowing us to work with a big number of people. We also did vaccination. So as before, planning vaccinations, it was the responsibility of a nurse. So here we added the vaccination against COVID, and we told our patients about the vaccines. We invited them to vaccination. We did mobile outreach with vaccination. We worked at the offices. So there was a lot of work for us. And then we started providing online counseling to the patients with chronic diseases, with asthma, hypertension, diabetes mellitus. So again, Ukrainian Swiss projects helped us, and there was a number of trainings on remote counseling. There were trainings with the psychologist to fight stress. And it added us some confidence, so we believed that we could do that, and we got the necessary knowledge, and we provide consultations. It was interesting for us, and it was useful and convenient for the patients because they could call a patient nurse, and it made care more available, more readily available. And what gave us even more confidence was the meeting in Lviv, where the teams from different facilities of the project, where we all came together, presented our experiences, our successes, because we all had our different experiences and successes. And here we also worked on our communication skills and on building the trust in the team. And here we started to understand that we are a part of the progressive community of this nurse community, and this community actually developing. We felt it. We understood that we are moving in the right direction. So we are doing the right things. So what do we have now? I think that is a success. We have nurses on the project, 4 of them in our facility. We have a special office in Helsinki cabinet, and we have electronic signature. We daily see 3 patients, getting 20 minutes for each patient. So we take the data about what they complain about, their anthropometric data, pre-doctor consultations. We enter that in the electronic system. We make the appointments. Also, a doctor can make an appointment, and sometimes we actually appreciate the support of the doctors, because, for example, the doctor says, with this problem, next time you can go to a family nurse, and she will be able to examine you and provide the necessary counseling. This improves the trust, the confidence in nurses on the side of the patients, and it's also a big boost for our morale because the doctors trust us. And we also practice making repeated appointments to the patient, for example, to control the level of blood sugar. For example, we provide recommendations on a diet and say for the patient to come back in months and show the diary of sugar levels, so they can make the appointments with us themselves. So we tell them that in a week and 2, they can use their e-health cabinet to get the appointment with the nurse. This saves the time for the patients, giving them more power sort of to plan their time. And we also do cancer screening. We invite patients ourselves. And that's mostly online counseling because we call the patients. We have a database of patients who have signed declarations with us. We invite them to such examinations and vaccination to the vaccination against COVID, routine vaccines, and counseling of patients with chronic diseases. Of course, we cannot prescribe treatment independently to them yet, only upon the prescription of the doctor, but we can consult them. We can provide counseling to the stable patients. We can consult them to help them know how to live with their asthma, with the diabetes, hypertension. We check their hypertension diaries, where they indicate the blood pressure, and we can provide consultation through telephone or through Viber. So we do everything in a way that is comfortable and convenient for the doctor, the patient, and us. We also provide consultations to healthy people, people without diseases. We have some occupational examinations. So we use everything you were able to find on the internet and different platforms. And this work books that we get from the project, they are very convenient because they have those QR codes with the links to the platforms where we can find a lot of information we use in our work. And of course, manipulations, that's rapid tests for hepatitis, HIV, and ECG measurement. We can do it ourselves in these offices of ours. And the next slide, the results we have got. What benefits it has for the patients? That's availability of the service. First of all, because for a patient to get prescription for ECG or for, I don't know, some tests, they don't need to go to the doctor. They can go to the nurse, and then having the results of the test, they can go to the doctors. We provide counseling in 20 minutes, and like it's more time. And to us, the patients come with different complaints. They come mostly to speak, to get psychological support, because we look at the patient not as a set of diseases, but as a person who has problems with family maybe and with health. The patients really love having a long conversation with the nurse because we are sort of their peers on the same level with them. And the patients are more aware, they're more independent, they know what complaints they need to bring to the doctor or to the nurse. Nurses have also benefited from that. We overcame our fears. We have more confidence in us. It encourages us to develop further because, for example, when we work with a doctor, patient asks something, doctor answers. But when a patient asks something from me, I must be able to answer those questions. And so that really encourages us to professionally develop. Like you start looking for some useful information. First, we had long preparation for that. We knew in advance what diseases the patients had. Now we are more confident about our knowledge and about our capacities. We've got some experience. We've improved our skills, and we are independent health service providers. Yeah, so we have more authority, more respect. Our occupation is more prestigious now, and doctors have benefited from certain patients. They know what the complaint is to be brought to the doctor and what is enough just for nurse. They save time and can pay more attention to complicated cases. And I would like to share one of the recent cases that we've had. Yeah, very briefly, Tatiana. Yeah. To me, a woman came who said, I know that my co-worker has a declaration with you. She came to you, you measured her sugar blood sugar level, and I wanted you task to measure my blood sugar level. So I did that. That was easy to do, and she had 12.6, which is 2 times above the norm. So on the very same day,
Пацієнтка була дообстежена.
Made her an appointment with her family doctor, and the patient received additional examination. She got the diagnosis and she's receiving treatment. So when I asked her, why didn't you go to the doctor immediately? Because we've been feeling for 3 months not well. And she said, like, oh, come on, that's a nuisance. I didn't want to, go to the doctor. So again, they see us as peers. It is easier for them to seek aid from a nurse. And the final slide, like, we've been able to make it, and you need to try it. Thanks to the project and the administration, because our manager is very progressive. So it has worked out. Everyone should try it because it's interesting. And if nurses tried this, I'm sure the results of the studies would be different. Thank you. Thank you very much, Tatiana. I will probably repeat now this question about the payments, about the wages, and I will ask Tatiana about this. From your experience,
означало розширення повноважень, розширення компетенцій.
has the increase of your role, has it meant the increase of workload, and has it been reflected in your pay? Well, the more, it's not so much about more workload, it's more about the increase of responsibility, because we did the same things, but together with the doctor. But here we have more responsibility. I enjoy it. My colleagues enjoy it. Because we are growing, yes, we are developing. When we went to this project, I actually was seeking this development because I had been a nurse for a long time. And my son said, okay, Mom, you're just a nurse. Come on. How are you going to improve? And I felt like, offended about my profession. I was not afraid of workload. And talking about the pay, it's always good when your work and your development is rewarded. So yeah, we have got some increase. Yes, some encouragement. Yes, thank you, Tatiana. Now I would like to invite the colleagues present here. If you have questions, please raise your hand or write it in the chat. You use this reaction hand maybe, or you can turn on your microphone and actually introduce yourself if you have a question to some of our speakers, or basically a question about the study itself.
Так. Я тоді
Well, then, if you let me,
ще раз продемонструю
I would like to
документ, де можна завантажити
show you again the link to the
що не бачу в чаті.
soft copy of the reports, a place where you can download it. Oh, I see Vladislav Drinsky has raised a hand. Yes, thank you very much, dear colleagues, for this interesting study and for this interesting presentation with practical cases and experience. I have a lot of thoughts now, but I just wanted to ask a question. Tatiana said at the beginning that they were planning another wave of studies, or maybe there could be another area to be studied. It's the education of the nurses. And before the work with the nurses started, if we look at this report, we see that they don't have sufficient sort of, doctor part. So there is a big difference between, in ideas between the managers and the nurses. They are less open to changes. So I just wonder where this thing happens. Maybe at educational facilities where the nurses are trained, they have their leadership killed in them, and that's what Tatiana said. You are just a nurse; you need to follow what doctor says. So if it's done at healthcare facility, maybe it should be studied. Maybe we need to look at the freshmen. Those who studied as a nurse for the first year, and compare their impression with the nurses included in the study. So probably it would be nice to check this human capital going to join this profession? And second question I have is to Tatiana. You have 4 nurses at your facility who have received this training. But what about the rest 100 or how many nurses you have? What is their attitude to these changes? And maybe another proposal, maybe such nurses need to have a special position, because if we speak about the standard of profession, the standard indicates the minimum for everyone, something that everyone needs to meet. And the differentiation, well, is important. In other countries, there are differences between different levels of nursing. So maybe within a facility, there should be different levels for nurses. So these innovators could be a step higher. Yes, and then so on like that, so that it could be reflected. Maybe it's 3 questions to 3 different people. Thank you. Okay, so I will probably first ask Darina to speak about the plans of the project, then I will give the floor to Tatiana. Yeah, talking about the education. In this study, there was a component on education and other things. We invite you to look into that because we've already have spent more time
впливу освіти, я не можу сказати, що ми там
well talking about this and we planned. And talking about leadership and the influence of the education, we did not look from that perspective, of course, but there was a lot of feedback on the lack of education on teamwork, communication skills, and leadership can be added there, I think. So I think that this gap is something that we try to fill in working with the pilot facilities, and we see how it actually has worked, how it really provided effect, and we understand that it needs to be addressed. Yeah, and talking about the education of nurses, training nurses, yes, under the project it's 4 nurses, but I believe that, of course, the project cannot train 1,000. It's not needed. The nurses need CPD, continuous professional development. Because having 1 training once in 5 years is not enough. And we are losing our skills and knowledge. We forget things. So continuous professional development would really help us in developing, because we could choose the areas, the topics, the webinars we need in our work, and not just they read us 144 hours of lectures, whether we need it or not. Maybe we will never use it. Yeah, it's good for like general improvement, but continuous professional development is something we really need. Okay, thank you. And I would like to, if you don't have any other questions or comments, I will try to very briefly sum it up. And yes, in the chat, you see the link. And I will try to show it once again. If you want to get the printed version, you need to complete a form in here. I don't know whether you see it on the screen. So I will try to sum it all up. Well, based on the study, we see that the primary care is ready to expansion of the responsibilities of the nurses, to strengthening the roles. And we see that nurses are more sort of pessimistic about that. And the source of that is probably the existing condition of work between the doctor and the nurse. And from the practice, we see that, yes, what is not forbidden is permitted, and the facilities can now make a decision themselves of how they distribute the roles and responsibilities between doctors and nurses. And while the legal framework does not establish strict limits for that, it is probably good, because those who are closer to patients, they can be more effective in identifying the model of sharing the responsibilities and the interaction. And the important factor for expanding the competencies and responsibilities is the ability of all primary care health team members to work as a team and communicate with each other, trusting each other. And for the nurse, it is important to feel the support from the doctor and trust from the patient. That needs to be verbalized, not just like, okay, the doctor needs to tell to a nurse when the patient is present, like, this person can be trusted in terms of health, and you cannot do it only through legal tools. The experience of facilities shows that the training opportunities from international projects, such as the Swiss-Ukrainian project, are important, and expanding the market of CPD with the focus on nurses is important and relevant, and it will open the opportunities for creating new role models for teamwork, to create precedents. It's something that inspires the nurses and gives them a better role. And let's not forget about health managers, because they see the benefit, very practical economic benefit, from organizing this work properly in primary care. And these benefits from strengthening the role of nurses, they need to be transformed into the incentives for the nurses in terms of pay, respect, communication within a team, so that everyone sees that the nurse has more responsibilities, and it is felt in the practice and in their pocket, actually. So there will be no quick expanding of the role of the nurses everywhere. It will be a step-by-step thing, and it will depend on the values and coordination of work in the team, including the nurse, the doctor, and the manager. And the cases in this report, they are a very good illustration of those areas that can be used as something where nurses can play a bigger part. So I encourage the doctors and managers to actually check those cases and think again about, maybe this is something I can delegate to my nurse, or maybe this is something I can have a meeting on between my doctors and nurses at my facility. So please pay attention to that. And thank you very much for today's thank you for sharing the experiences of this pilot project and your opinions about how it should be done. So I really hope that things that Vladislav asked about, the next waves of the studies and the results of the pilot project for advanced nurses, I think it will come soon. We all are in close contact. There are emails and social media. So thank you for today's meeting. If you have something to suggest, you can always find us. You know how to reach us. It was nice to see you. Have a nice and peaceful evening.